So first some of you know how I met Gordon, but I figured I'd talk about it. I think it's appropriate at this meeting. But 2012, he came to speak at Arthrex about ACL repair with internal brace augmentation. And he was wearing his kilt with a polka dot tie and some horn rimmed glasses. And I probably had some of the same thoughts that Rob LaPrade was having when he walked out of the Vail meeting. And many of the people in the audience did as well. And you know, I tell this story affectionately because my mom always said, if you don't have anything nice to say, don't say it. So, but I definitely have lots of nice things to say about Gordon and what he's done to help shape my career over the last 10 years. At the time of the meeting in Arthrex, I was taking care of the Washington Nationals baseball team, and one of our players had gone down with an ACL injury, and he was Venezuelan, and I said, well, listen, we're going to do a patellar tendon reconstruction of your ACL, and you're going to be all better in 8-9 months. And he looked at me and he goes, hey, Papi, I love you, but my agent wants me to go see this guy, Dick Stedman, in Vail, Colorado. And so he flew out to Colorado, and I got on the phone with Stedman after he evaluated him. He says, you know, I'm going to poke some holes in the bone, stimulate a healing response, and I'm going to lay the ligament down, and then he's going to be fine. And I thought to myself, Jesus, that's crazy. And I couldn't say anything to him. And obviously Dick Stedman, world-renowned, number of athletes that he's gotten back, all the skiers and athletes from around the world. So I took a deep breath, hung up the phone, and I called Jim Andrews immediately. And I said, Dr. Andrews, I said, what do I do? You know, I said, this is our starting catcher, going down with an ACL tear. We can't let him have this surgery. And he goes, man, you got to let him do it, but tell your GM to get a new catcher for next year. And so, sure enough, he had the surgery done by Dr. Stedman. We got a new catcher, and he came back at 8 months, and I evaluated his knee. And I did the Lockman test and the pivot shift, and it was negative. It was completely stable. And I thought, this is crazy. And so I'm sitting here trying to rip through the scar tissue. I did the Lockman about 3 or 4 more times, and it didn't do anything. He played for 4 more seasons. So he played for 4 seasons, and at the end of that 4th year, towards the end of that 4th year, he was going for a pass ball and tore his ACL. And people started calling me saying, you know, I told you so. I told you. You were right. You should have had the BTB reconstruction. That was ridiculous. But that's not what I was thinking at that point. What I was thinking at that point is he played 4 more seasons as a professional MLB catcher. So this was really revolutionary. It's really got me thinking. And in 2014, I invited Gordon to Washington, D.C. He came and showed me a bunch of testimonials, and I started doing the surgery. My first one was on a young yoga instructor, a male yoga instructor, and he said, look, doc, if you do an ACL reconstruction on me, I can't teach. This is my livelihood. I need something else. So I said, well, I have this new surgery. It doesn't burn a bridge. We can try it. We'll see what happens. And so we did it. He came in at 5 months, and I said, hey, okay, well, we're ready to send you back to, or I think 3 months. We came back. So we're ready to send you back to yoga instruction. And he puts his head down and he goes, I've been back doing this since 2 weeks. And again, light bulbs went off. And so this has just snowballed, and I'm going to talk a little bit about my experience, some of the research that I've been doing, and this has become an integral part of my practice. And while it's not the majority of cases that I do, there's absolutely patients for whom I do this, and I certainly would want it myself in the right situation. So the current gold standard we know is ACL reconstruction. There's high rates of patient satisfaction in the short and medium term. Everyone seems to quote about a 4 to 8% failure rate. And there's a massive body of literature showing significantly improved functional outcomes after ACL injury. But I think we have to question ourselves, and we're in the age of big data, and so we can't just say 4 to 8% failure rate defined by a Lockman test or a KT2000. Is the gold standard really gold? Well, Ross's study in 2020, systematic review of return to sport in the NFL, showed that only 67% of players operated by the best surgeons who had conventional ACL reconstruction returned to play. Oops, there's a little flash on my screen here. There we go. And the majority of the football players experienced greater declines from their pre-injury levels when compared to controls over that same time period. So what we found was that the people who were getting back often were excellent players who were now average. So there was a significant decrement. This is not a perfect surgery in these athletes. And then Jensen just published a study this year, another systematic review, looking at who did not return to sport after primary ACL reconstruction. There was a rated rate of failure of return to sport of 25.5%, and the most cited reason was actually fear of re-injury. So factors independent of surgical outcomes may impact an athlete's ability to return to play. Proprioception, there's all kinds of things that come into play that may have a psychological impact when you do these conventional ACL reconstructions. And we're stuck. Let's try this. So looking at the rationale for reviving ACL repair, we may have been throwing out the baby with the bathwater. There have been significant strides in the past 30 years, including the advent of arthroscopy, MRI, understanding of anatomy, technical advances, understanding rehabilitation principles and surgical materials. I remember, if you can imagine back when they first started doing ACL repair, you got locked in a cast with the knee flexed 20 degrees for 6 weeks. There couldn't have been a more perfect recipe for failure. The only reason the ACL reconstruction outdid it was because it was stronger than the native ACL. The native ACL is not a strong structure. When you guys when you guys who are doing knee surgery clean this thing out, it's wispy. But it has Ruffini fibers, it has Pacinian corpuscles that send a message to the brain. It's kind of like a quarterback in American football. If he doesn't have a good line to protect him, he can't be any good. The same thing with the ACL. You need dynamic stability, and so the ACL signals the brain to tell these muscles to fire in coordination to protect it. And when you have a conventional ACL reconstruction, it just doesn't happen. So there's an increasing body of evidence that suggests suture-augmented ACL repair is a viable alternative to conventional ACL reconstruction in select patients. We also see now, looking back, that we may be not as bad as we thought. If you look at older studies, Fagan and Curl's original article in 1976 showed 94% of patients reported some subjective instability and had 50% unacceptable results. Well, Dean Taylor in 2009 revisited this study, and he found that the 50% that were actually normal and nearly normal remained so at 30 years. The same cohort that had done well in 1976 showed 20 of the 34 had greater than 80 on their Leishholm score, and their IKG subjective and objective scores remained excellent. So there clearly is a subset of patients that seems to do well with ACL repair. Marshall's study in 1982, 69% return to play at 2 years. Houston, 71% return to play at previous level, 94% were satisfied with the outcome. Those numbers don't sound so bad in the context of some of the current literature that we have on ACL reconstruction. We all know Sherman classified ACL tears back in 1991. Type 1 is avulsion off the femur. Type 2 is up to 20% left on the femur. Type 3 is a tear at the proximal 1/3 distal 2/3 junction. And type 4 is a mid-substance tear. And he found a trend toward higher success with proximal tears rather. So good results with modern day techniques. Di Felice, I have to say, now I'm in Italy, I have to say Di Felice. He calls himself Di Felice in New York. Capiche? So Kista in 2019, suture button technique. He had a case series where he showed 7.4% failure when using the IB, the internal brace, 13% when he didn't use the internal brace. Scythe in this study in AJSM in 2023 was a retrospective study, cortical button technique, match pair comparison, found no difference between groups across PROs at a minimum 2-year follow-up. And the forgotten joint score 12 was statistically better in the ACL repair with internal brace group. Muller's study in 2023 was a cortical button technique. He had a level 3 match comparison study, statistically significant improvement in all PROs, and there was no difference between the internally braced ACL and the ACL reconstructed knees, so pretty good. So what's my experience with ACL repair? Well, as I said, I did my first patient in 2014, and in 2020 I decided to do a look back. I did a retrospective study and found that 23 of the 27 patients that I'd operated on had successful ACL repair with no clinical instability and no complaints at final follow-up. So 14% required revision to ACL reconstruction. But all of those patients returned to activity at their previous level. 11 of the 27 patients with successful ACL repair had preoperative baseline data, and they showed statistically significant improvement that met MCID criteria for each of the PROs that you see listed below: the KOOS, the composite WOMAC, the VAS pain, physical VR12, and the SANE. So then I decided to do a prospective study, and I remember Di Felice calling me and saying, "Hey, listen, why don't you join me on these studies? And I said, you know what, we need good quality studies. We're getting hammered about this topic. And so I designed a prospective level 2 comparative study with the help of Arthrex to look at ACL repair with internal brace augmentation compared to conventional ACL reconstruction. Looked at 60 patients, 30 of them had ACL repair with internal brace, 30 with conventional ACL reconstruction, and 91.6% were available for follow-up. I had 3 failures in the suture-augmented ACL repair group. The average age of the failure was 19.6. The average age of the untorn was 24.6, and we'll come back to this in a slightly later slide. I had no tears in my conventional ACL reconstruction group. I was hoping I had one or something like that, but we didn't have any re-tears. Interestingly, I did, most of the patients that I did reconstruction on, I also used the internal brace. So looking at the patient-reported outcomes, there was a statistically significant improvement across both groups, the IB repair and the reconstruction groups. But there was a statistically greater improvement at 3 months and 6 months for the IKD subjective and Tegner score measuring activity level with the IB ACL repair compared to the ACL reconstruction. So what this meant was I was able to get these folks back to regular everyday activities earlier. In some cases, they were able to get back to sport earlier. And there were no significant difference between any of the PROs between ACL repair and conventional ACL reconstruction at 2 years. So what are the controversies? Which type of tear? The elite athlete? There have been case reports. There was a 4-month return to Olympic skiing. Bertrand Coté had a skier that he got back to the Olympics at 4 months. I had a young lady that had torn her ACL. She had lost all her Division I college scholarships after she tore it, and she said, "Doc, I need to compete in the Penn relays in 4 months or I'm screwed." So we did the surgery on her after kind of going through everything, and she was able to return. She had her personal record when she returned at 4 months and got a 4-year scholarship and competed in hurdles for 4 years with the ACL repair and internal brace. Young or old? Which technique? Suture anchor, cortical button. So this tear here maybe looks like a Sherman 2, but actually that's just scar tissue more proximally. This was a Sherman type 4 tear. This is not one that gets an ACL repair with internal brace in my clinic. This tear looks like it comes right off the edge, but actually was a Sherman type 2. We ended up repairing this person. They got back to skiing with no issues. Sherman 2s are still the ones that I sort of debate about whether they get them or not. It really depends on the type of patient. You need to have caution in younger patients, period. Albright's study showed a dismal 48.8% failure rate in pre-adolescent and adolescent patients undergoing ACL repair. Scythna had a statistically higher failure rate with ACL internally braced repair versus reconstruction, a 5.38% overall failure in the ACL repair group versus no failures in the conventional reconstruction group. But he found there was no difference in the failure rate statistically when the patients were over 21. In my study, we had a higher failure rate in younger patients, as I mentioned before. The torn group was 19.6 years old. The successful ACL repair group was 24.6 years old. But, and people don't like to talk about this, like to jump on the ACL repair, care should be taken in the young cutting and pivoting athletes in general. So there's high rates of failure in this group, repair, reconstruction, period. Paterno's study in 2019 showed a 29% new ACL injury rate after conventional ACL reconstruction, and this was 6 times higher than uninjured controls. Wiggins' meta-analysis in 2016 showed a 23% failure rate if under 25 and returning to cutting and pivoting sports. So there's multiple probable contributing factors. The volume of work in this young elite athlete population is important. They're also developing their neuromuscular coordination, and as we talked about before, proprioception is important in protecting the native ligament. And then there's lower joint stiffness, and I don't mean pathologic stiffness, but I mean the ability to dissipate load by contracting muscles and making that knee joint tighter. So indications for ACL repair. First of all, we have to talk about the facts. There's limited high-quality evidence. It's increasing. There's no question about it, but there's a trend in favor of better results with proximal tears, and I stick to proximal tears. I'm not a bear person. We'll be talking about that, I think, tomorrow. A number of recent studies demonstrated good results in the short term with ACL repair for proximal tears, but there's a higher incidence of re-tears in younger patients. The indications in my practice: 25 to 55-year-old healthy fit with moderate pivoting and cutting activity, even competitive. Sherman type 1, maybe type 2, and high-grade partial tears. They have to have good tissue quality. And if there's a desired return to play in season, Gordon actually just helped coordinate a young lady get to my clinic from Seattle, Washington, who she just wants to finish her senior year and then she's going to play recreationally. We fixed her. I think she's going to do beautifully, but this is one of the considerations as well. If they have to get back within a 6 to 9 month period, that's not going to happen with the conventional reconstruction. And the patient has to have a solid understanding of the risk, benefits, and alternatives. There's actually a case under review where the patient got an ACL repair and she didn't understand what a repair was, and she's angry at the surgeon that did the repair because she didn't feel like she had an adequate explanation of what's going on. So adjustable loop tension is my technique. This is a game changer. I used to use the technique that Gordon taught me where I actually tie down the ligament, but this adjustable loop tension device that was recently developed through Arthrex is brilliant. So here it is. Here's the ligament. This was a Sherman type 1 tear that was completely torn off. There's the exposed notch. I make a little hole in the bone with a burr before I poke holes in the bone to stimulate a healing response to identify where I'm going to go in. Here's now the power pick that I'm using to stimulate the healing response. I'm passing a passing suture. And here I have 2 separate fiber ring sutures. One's 35 millimeters in length and one's 25 millimeters. I space them a centimeter apart, and this helps distribute the tension. It's not just a single suture, and I'm not beating up the ligament. Then I link these together they have a special card that you use to create a reverse tensioning adjustable loop device. And I'm locking the button on the lateral femoral cortex. Once these have been linked together, then I draw this into the joint. I make sure the button's locked. And then once it's locked, we can pull these sutures in. You use a winch mechanism to tighten down the repair. And there it is. And actually, once you've done this, you're really you can test the ligament now. The beauty of this technique is you can test the ligament stability before you tension the internal brace, so that you're not fooled into thinking that the internal brace is doing all the work. You know that you've got a good repair. Here we are passing the internal brace down distally, which we'll fix with a swivel lock anchor on the anteromedial tibia. And there we are, we're done. So the reason I like the adjustable loop tension device is that you can assess the integrity of the repair prior to internally bracing it. It's strong cortical fixation, there's no anchor pullout, you have the ability to retension, and there's really a small footprint affected, so if revision's needed, you haven't burned a bridge. So little technical pearls, I use a mini C-arm to confirm that the button's fixated on the lateral cortex. I assess the repair before internally bracing it. I don't over tighten it, it's just a check rein. I use a microfracture technique or equivalent. And then you don't want to over tension the winch mechanism because it can pull the suture out of the tissue. So in summary, ACL reconstruction is the gold standard. But concerns remain about return to sport, osteoarthritis, recurrent knee injury, and the feel of the knee. There's promising new data supporting modern day cortical button internally braced ACL repair, but there are concerns over the results in younger patients. We need more high quality data to validate the current body of evidence, but I think we're headed in the right direction. Thank you.